afternoon. My name is Jessica Jolly, and I am the Senior Director of Practice Advancement with the American College of Lifestyle Medicine. We are so glad you decided to join us today as we discuss food is medicine and nutrition equity. Before we begin, we'd love to briefly share a bit about the American College of Lifestyle Medicine, or ACLM. Lifestyle medicine is a medical specialty that focuses on using evidence-based lifestyle interventions to prevent, treat, and in many cases, reverse chronic disease. As a professional medical society for lifestyle medicine, ACLM supports and equips current clinicians as well as the next generation of healthcare workers to put lifestyle medicine at the center, advancing a high-value, patient-centered, and equitable standard of care. Next slide.
Working on it. There we go.
We invite you to join ACLM if you're not already a member. Benefits include discounts on educational courses, a full subscription to the American Journal of Lifestyle Medicine, free credit hours, and much more. So please join us and become a member. Next slide. An example of some educational content offered by ACLM relevant to today's presentation is our Food as Medicine series. As one of the key pillars of lifestyle medicine, healthful eating has the power to help prevent, treat, and even reverse many chronic diseases. Yet most clinicians do not receive education on food as medicine. This course series will educate and equip clinicians with knowledge of dietary patterns shown to prevent, treat, and reverse diseases such as heart disease, diabetes, and certain cancers as well. And this will also prepare them to implement food as medicine at a practical level in patient care. Next slide. And one more resource we want to spotlight today is our free, ready-to-use 9-session culinary medicine curriculum based on the groundbreaking work of Dr. Michelle Hauser. This highly versatile framework can be integrated in various education and community settings. The program and curriculum establishes a strong foundation in culinary medicine and is a key part of supporting patients in achieving better health outcomes. Next slide. During today's webinar, you will learn about the history of the Food as Medicine, or FIM movement, and best practices in FIM program design to ensure programs are ethical, equitable, trauma-informed, and patient-centered. Please feel free to submit any questions you may have in the Q&A box. We will have time for questions after the presentation, and I'm so excited to introduce today's speaker, Dr. Mariana Wetherill. Next slide. So Dr. Wetherill is a registered dietitian and population health interventionist with over 20 years experience in community-based nutrition. Her work examines the influence of nutrition insecurity on personal dimensions of well-being, self-care, and health risk behaviors. Her current research includes 2 NIH-funded FIM research studies that aim to evaluate the impact of trauma-informed, medically tailored food assistance interventions for people living with HIV and Indigenous people who are pregnant. Dr. Wetherill is the lead dietitian for the University of Oklahoma Culinary Medicine Program, program director for the OU Food First Pharmacy, and is a founding course director for 3, not 1, but 3 lifestyle medicine classes required for medical and physician assistant students at the OU Tulsa School of Community Medicine. It is my pleasure to now introduce Dr. Wetherill and hand it over to her. Thank you.
Well, thank you so much. And I just want to acknowledge, how grateful I am to be here today. This session was originally proposed as a breakout session to be in a very small conference room at the ACLM conference. And I was just very grateful to be offered the opportunity to be with you all today. And I just want to acknowledge the collective community that we have here, looking at the number of registrants that we have that are all interested in this topic. So before I even get started, Thank you so much for your commitment and your work in this space. And I know that we have at least one culinary medicine alumni on this call today. So hello. As lifestyle medicine practitioners, we are faced with the challenges of a complex malnutrition epidemic that we know too well, that is really disproportionately impacting those at the highest risks for chronic disease and disability in our community. Most scientists agree that the foundation of a healthy diet should include a wide variety of minimally processed foods, including what I have depicted here on the screen, with around half the plate consisting of those really deeply colored vegetables and fruits that should be complemented by some intact whole grains, lean proteins that at least include some plant-based sources, and a lot of those unhealthy fats, ideally in their whole food form, nuts, seeds, avocados, olives. At the population level, we know that low intakes of these foods are independently associated with an increased risk for certain cancers, type 2 diabetes, cardiovascular disease, hypertension, all-cause mortality. The list goes on. But most importantly, we have notable disparities in intake by both education and income within most of our communities and the patients that we work with. At an individual patient level, many of the foods that form the basis of the therapeutic diets that we prescribe in lifestyle medicine come in the form of these positive nutrition prescriptions, with some examples of, eating several cups of dark leafy greens or a handful of nuts and seeds each day. And this deficiency in a whole foods diet is worsened by excessive intakes of too many ultra-processed foods that we know are designed to promote overconsumption and that lack many of the essential micronutrients and other antioxidants needed for the body's defense and repair systems. And this negatively harms our longevity potential and overall quality of life. And it's not just physical health that's being compromised by this state of chronic malnutrition. We have more and more studies coming out that show mental health sometimes equally, if not more, suffers and is negatively impacted by regular intakes of sugar-sweetened beverages and fried foods, which are also disproportionately marketed and available to people who live in lower income communities. And thus, we know food is an everyday exposure that can dramatically influence chronic disease etiology and pathology. And due to its central role in shaping patient health outcomes, the American College of Lifestyle Medicine has been a leader in providing that continuing professional education for physicians and other members of the healthcare team, recognizing that we all have a role to play in digging ourselves out of this malnutrition epidemic that we face. But beyond ACLM's internal community, we're at a really exciting time where both the scientific and general public both agree on a shared interest in seeing more food being integrated into their medical treatment options. On the left here is a figure of publication counts for PubMed indexed peer-reviewed journal articles beginning as early back as 1945 all the way to the end of 2025 that included the key terms food is medicine or food as medicine. And then on the right, we see Google search trends. The blue line on top is food is medicine, with the orange line on the bottom being food as medicine. And together, these figures illustrate pretty strong alignment that's happened over the past 5 years or so with both scientific community and general public interest on this topic. And this idea of synergy and interest is further confirmed by a recent report that was put out by the Rockefeller Foundation on public perceptions of food as medicine that not only suggested really strong bipartisan policy support for this topic, but also very strong agreement among both surveyed healthcare providers and patients that they want to see food playing more of a central role in their medical treatment and options. But the concept of prescribing food to improve health is certainly not new. Food was part of all traditional healing systems around the globe since the dawn of time, and it was only recently omitted from conventional medicine due to these perceptions of the superiority of prescription drugs for the treatment of modern, what we now call man-made diseases. And when it comes to current knowledge on prescribing food within the context of improving health, actually much of what's known can be thanks to intervention models and lessons that were actually derived through community-based responses to public health needs that were largely formed outside the healthcare system. Today, the terms medically tailored groceries, medically tailored meals, produce prescriptions that are all commonplace in food as medicine conversations actually were born out of grassroots community actions to tackle the malnutrition epidemic that we have today. So where did, these intervention ideas really come from? By and large, a lot of these models were developed over the last 20 to 50 years, often beginning with very small, local community responses to the needs of marginalized people at nutrition vulnerability in their communities. So I want to acknowledge this is not an exhaustive list of examples, but going back even to the 1960s, we saw examples in history of actual prescriptions being written out of community health centers to address malnutrition with food. In the 70s, WIC was piloted and rapidly adopted into national policy. And now many people view WIC as our nation's largest and oldest food as medicine program. And less people know about the Ryan White Care Act and its role in providing access to medical care for people living with HIV. But within part of that legislation and policy, it actually named medical nutrition therapy as a core medical service. And even within that, it additionally named the provision of medically tailored foods and supplements as core medical services. So today we call these ideas medically tailored groceries, but really they were born out of a lot of community level, public health level responses of trying to address people in their nutritionally vulnerable states. The HIV epidemic also played a very central role in the formation of medically tailored meal organizations that we have today. And I've bulleted out kind of some key timelines that are further explained on the Food as Medicine Coalition's national website that I encourage you to visit. But in the early 80s, at the beginning of the HIV epidemic, as people were dying of malnutrition, we saw medically tailored meal organizations form out of local communities as a strategy to try to combat that wasting and to help people manage a lot of the very brutal side effects of HIV. In the 90s and the 2000s, early 2000s, we saw the expertise of these organizations growing and working to expand their mission to respond to the acute needs of people with chronic illness. These organizations formed a collective known as the Association of Nutrition Services Agencies, where they introduced this idea of food as medicine. And then as ANSA changed and some of those members disbanded and reformed, that's where the Food as Medicine Coalition came to being in the 2010-2013 area. And we have a lot of the work of these community-based organizations to thank for the knowledge and the advocacy and the really huge work behind demonstrating that medically tailored meals can be very therapeutic options for helping to turn patient outcomes around. And then finally, despite plants being the basis of all life on this planet, the concept of a produce prescription is actually kind of new among all of these food as medicine models where we look at the timeline. But they have grown exponentially in recent years due to the legislation that was passed that really helped to fund their future or their rapid scaling through USDA. And so as a result of all of this more recent enthusiasm about food as medicine and defining these models, we have a lot of work going into even defining what this is. And so what I have here is some shared language about how this term is even being used within the healthcare sector now. And so we have this spectrum of programs and services that respond to a critical link between nutrition and health, and that the interventions to include an actual provision of food, and has to align with the healthcare system. The Food as Medicine Coalition supports this definition, but also says these food as medicine strategies really need to be contextualized within a broader intervention framework in order to be able to achieve the intended outcomes. American Heart Association has been a leader recently in this space, defining this as the provision of healthy food integrated within the healthcare sector. And then other larger institutions at academic universities, such as at Tufts Food as Medicine Institute, recognizing this set of food-based nutrition programs and interventions that we're trying to integrate. And so the inclusion of food now within formal healthcare prescriptions, and thinking about it that way, significantly expands the range of stakeholders that now have some vested interests in food as medicine policy. And while that can be a very exciting time for those of us that have been engaged in this work, it's also a very pivotal time, I think, as well. Depicted on the slide here are just some examples of food as medicine stakeholders, not an exhaustive list, but just trying to give us some idea of who is entering this space that has a role to play in policy and program design considerations. And as additional viewpoints and special interests move into this arena, from an equity perspective and an accessibility perspective, it's really critical that we remember that patients, caregivers, and the local community need to remain at the center of this decision making of what food as medicine looks like. In particularly, we need to ensure that the needs of marginalized, nutritionally vulnerable populations are prioritized, because these individuals face the greatest barriers to accessing medically appropriate foods. And for additional reading on this topic, I would really point you to this recommended reading on top on the topic and the vision of what food as medicine could look like from a generative perspective. So just briefly, I know many people on this call are familiar with these models: medically tailored meals, groceries, produce prescriptions. So these are really just summative of what is known, and I would encourage you to download the Aspen Institute Food as Medicine Research Action Plan that summarizes and really dives into all of these intervention models. But I want to point out that for these medically tailored meals, the registered dietitian has always been a central part of these models, and the role of that IRD is to help achieve that high level of personalization that is needed among people that are most nutritionally vulnerable. And the design of a medically tailored meal intervention is high dose, highly therapeutic, covering the vast majority of calorie and protein needs, also therefore the most costly, of these interventions that we have on a per patient basis. But these are certainly needed options and high impact options when they are connected with the right patient at the right time. And I would argue that really we should be thinking about patients with limited mobility, those with limited cognitive capacity, or that are being asked to follow highly specialized nutrition prescriptions that can be very difficult to implement, as really the ideal candidates for a medically tailored meal intervention. Now, medically tailored groceries do require participants to perform some degree of food preparation on their own. Right? This is, yes, of course. But the degree to which medically tailored groceries are actually accessible to a priority population is really going to depend on what foods we're actually offering, right? And what's realistic. So, thinking about factors about whether or not these foods are home delivered versus pickup, how much choice is actually involved in that the patient has on what kinds of groceries they're going to receive, and whether the program provides additional supports tangibly to do the behaviors that we're wanting them to do. Do they have a way to actually prepare these intact whole grains that you're giving them, or prepare these dry beans? If not, that's where some program design elements will come in that do have equity implications for people's ability to fully participate in this type of an intervention. And finally, produce prescriptions have become quite popular recently, perhaps due to this kind of simplistic emphasis on a single food group, right? That we know is a foundation for good health. And nearly all therapeutic diets have fresh produce or some type of produce in there as a core component. However, there are a lot of accessibility opportunities for produce prescription programs that we really don't see being fully integrated in these programs that are being implemented to date. So if, for example, there's a lot of opportunities for offering more frozen and dried shelf-stable produce options, for example, offering produce in a pre-cut form rather than in a whole form, the home delivery element, better inclusion of produce options that are most familiar and common day to participants, so that they feel familiar and more confident in being able to prepare what's being given to them. And then also in our experience in Oklahoma, in the very early piloting of these programs 10 or 15 years ago, we found that a lot of our patients took their produce home and attempted to cut it on a dinner plate and with a butter knife. And so we quickly learned through some of those, initial lessons and working with community that these produce prescriptions, in order for them to be truly accessible, just like medically tailored groceries, we need to make sure our patients have the tools that they need in order to perform the behavior at home, not just recipes or education, but sometimes those additional tangible aids to help them get there. And as I've alluded to in this, really brief overview of these 3 food as medicine models, each one of these intervention modalities are aiming to implement a very simple concept, right? Improving health through better nutrition. But in reality, there are many, many design considerations that we have to consider for each of these models that will have major implications for their accessibility for the marginalized and other nutritionally vulnerable populations that we are trying to help. What we're really dealing with is not a simple intervention. It's a simple concept, but what we actually are being faced with is a complex healthcare intervention. So what is a complex intervention? I pulled together some definitions here, and we're going to read through them. And as we read through them, I'm really curious, based on your experience working with food as medicine programs, how you see complexity being woven into your decisions and evaluation approaches. So feel free to type those in the chat as we work through these definitions. But the first definition here is a complex intervention intervenes and disrupts the functioning of a complex system by changing relationships, modifying or transforming established practices, and redistributing resource allocations at the hospital or patient level. That sounds like food is medicine to me. And then another definition that we can look at here, when there are multiple components or mechanisms of change that we're trying to maneuver, and then when the outcomes from an intervention are dependent on external factors, like the characteristics of a participant or the context or system that the intervention actually operates. So again, for those of you who have been working in this space, I'd love to see some of your ideas about what makes food as medicine interventions complex from your point of view. And really, challenge us all to think about how the design of these programs really do impact their accessibility and all of these complex factors that sometimes we might take for granted, might not really even think about, assume are operating in a certain way, and they're actually not. Because if we take the time to go back and not just think about the what kinds of foods we're going to be providing, but how they're going to be provided, who we're trying to reach, why are we even doing this, can really help you to identify those design elements of making a person-centered, patient-centered, complex intervention reality. So for those of us on this call who, have attended food as medicine conferences or continuing education, I know you have seen this pyramid many, many times ad nauseum probably. But the reason why I put it up here though today was to just remind us that these different approaches should be designed and selected so that they're the right fit for the right patient at the right time. And we need to be committed to that goal before we even start with the program design process. So really taking the time to not put the cart before the horse, not saying, oh, I want to start a produce prescription program, or, oh, wouldn't medically tailored meals be great? But really taking a step back and doing the pre-implementation project scoping work that involves engagement with communities to hear what they want and how they want it, so that we can truly work in partnership with the people that we are trying to help. And so this slide here, we're going to be spending a little bit of time with it. Sorry, it's not more animated or beautiful, but this is what we've got. But as we start unpeeling the layers of a food as medicine intervention as really a complex intervention in healthcare, we do start to see how many decision points we need to go through that will have huge implications for the ultimate outcome or how well a food as medicine program is going to work. So layered throughout are important considerations for equity that are going to play a huge role on that accessibility component, and how many people can actually be reached through the interventions that we're working to design. So beginning with patients, this first row up here on the figure, the knowing that we want them to eat healthier, right? That's the easy part of the goal, right? That we want them to consume the food, but it's really crucial that we work back in how that's actually going to happen. We first have to figure out, how are we going to overcome that challenge of patients even being aware of the program and how to access it. And then thinking through those program logistics, how many steps are they actually going to have to take to get the food? And as we established on the initial slide, many of the foods that we are writing these nutrition prescriptions for are not part of people's usual diets. So we need to be anticipating some preparation challenges, and simply providing people a recipe in a food box is not sufficient. And then also thinking about those household dynamics, right? Food is very much a family level experience. So thinking about family level program design is essential for ensuring these remain patient-centered as well. And again, this is where a lot of that pre-implementation planning can play such a huge role in ensuring your planned activities align with the kind of experience that a patient needs. We've actually developed through the Kansas Food as Medicine Initiative some project scoping worksheets that are free to access for anyone that can help you walk through a lot of these steps. And so, looking now at this orange box, sometimes this is the afterthought, if not any thought, I've noticed in many of these food as medicine program designs. But they certainly help to define what makes them complex. They are challenging a healthcare system, a clinic, a provider to modify their own behavior too, right? And how they're using nutrition as part of their treatment planning. At minimum, we're now asking providers to be willing to routinely screen and discuss a new program with eligible patients. We know that this is an important step because through lifestyle medicine key learnings, we know that power of physician advice and actual prescribing is a really essential part of getting patients to even sometimes think about the health behavior change that we want them to be doing. Other decision points in this domain also include within the team. Who's the best person to be playing a role in program intake, monitoring, managing of patients to ensure that the actual logistics of the program are performed regularly? But from an equity standpoint, we've found a tendency in some settings to initially place this burden of managing a food as medicine program on staff who are already stretched way too thin and over capacity. So while on one hand, we know that food as medicine can really give providers and whole care teams a new source of professional purpose and meaning and fulfillment in their jobs, we also have to make sure that the adequate resources are there to allow them to achieve that experience. We found that community health workers, registered dietitians, and I would also argue occupational therapists have really central roles to play in making sure that system works. And additionally, we have some equal considerations that really need to go into the selection of our food vendor. I've been in this space for 20 years, so I know others have been in it longer, but based on my time, I have found regularly that there is no better partner than local food banks. They know the priority population well. They've been serving the same communities for decades. They know how to source large volumes of food that can be quality foods if they have the money to purchase them at discounted rates. And they also have distribution in place that often will go to rural areas that other vendors won't service. In my state of Oklahoma, our food banks service 1 in 7 people who live in our state. And so really, in my opinion, we have to reserve a seat at the table, at this planning table, to ensure that our food banks have the choice and are invited to be part of building out this critical food as medicine infrastructure. And then finally, we've got a lot of other stakeholders, as we work with potential public and private players and thinking about reimbursement and what's a covered benefit, et cetera. What is participation going to look like? What about when the active stage of that program ends and people then re-enter a period of life where the benefit isn't covered anymore? There's a lot of ethical challenges and equity considerations that need to play out and be thought through as well. So over these next few slides, I'm just offering some behavior change frameworks that you might find useful as you're doing that introspective process of, how can I make my food as medicine program more accessible to the people that I'm trying to help in my clinic or in my community. And this first framework here introduces, really the more of the psychological or the cognitive side of what happens as people move from an action or an initiation stage of change for any kind of a health behavior to a maintenance stage of change where that behavior is really automatic and they're not thinking about it anymore. And so what we can see here at the beginning on the left of this figure, the cognitive burden of change is actually quite high at the beginning of an initiation of any kind of behavior. It's particularly high for eating change because eating is really actually a constellation of behaviors, right? There's thinking about food procurement, thinking about food preparation, thinking about how am I going to remember to eat it in my busy day? How am I going to navigate household member family dynamics? A lot of cognitive thinking has to be going on at the beginning of that initiation. And that's why supportive food as medicine activities can really make or break someone's decision to continue going on in a food as medicine program. In our experience, also, many people, particularly people who have been living in poverty for a long time, but not necessarily just poverty, they begin their food journeys not really knowing how food might be connected to deeper internal values that define them as a person. And so part of a food as medicine program, there really should be some kind of a activity allowing people to visualize and see how these new choices contribute to their own life purpose and meaning. And that process of growing out that centered identity where the food choices and the things I'm putting into my body are more directly connected to the things that define me as a person, we know makes that behavior far more maintainable. And so I've provided the citation for this framework if you're interested in reading more about it. And then, drilling down a little bit more into the populations that can be served best, I would argue, through food as medicine and that have the most to gain are really those affected by limited resources who are living in an environment of poverty. And so as we're thinking about what prevents people from viewing and using food as a tool that can transform their health, there's been a lot published on food choice values to help us, kind of think a little bit about this. But for our time today, I thought it would be best to introduce, or at least remind us of the cognitive burden of poverty. For patients with limited food resources, we need to consider how that cognitive burden or how that poverty is affecting their cognitive capacity to view food as medicine as even a treatment option that's viable for their daily lives. And so beyond well-established deficiencies in health literacy, we also need to consider how toxic stress and the cognitive challenges of daily survival might be competing against our patients' capacity to proactively participate in a vigorous lifestyle medicine, healthy eating treatment plan. So for patients with limited incomes, particularly Medicaid beneficiaries, we really do have an ethical obligation to design our food as medicine programs in a way that incorporates this lived experience, that recognizes a lot of decisions are being made day to day instead of future oriented. And the program must be designed in a way where it's taking a burden off the participants so that the new behavior is actually easier for them to do than maintaining the status quo. So for this presentation, we've kind of, used some different terms that are related and I think, interchanged quite often in conversations, and that's food is medicine versus food as medicine, only being separated by a word, is or as. And as I've come to work and develop my experiences in this space, I've come to really value and appreciate the power and the meaning of the selection of words. And so I am now very intentional with how I describe these two intervention modalities. I know that the National Food as Medicine Coalition had similar conversations whenever they were thinking about, what should we call ourselves, and what the work that we do. So should it be is? Should it be as? What's the meaning of those two terms? And ultimately, regardless of the term we use, I think the goal for us is to have that empowered patient, right? We see food as a way of empowering patients, and probably more accurately trying to empower families to have more control over what their life course health is going to look like. But when food insecurity is at play, we know that the limited access to food can fight against patient capacity to engage fully in all their healthcare. And this goes far beyond healthy eating. So the cognitive burden of poverty not only impedes, consideration of, making a healthy eating change, but it can also affect a patient's ability to engage with other aspects of their medical treatment plan. It can prevent them from eating the healthy foods that they want to eat, that they just can't afford. It might contribute to other health risk behaviors, such as using tobacco to cope with hunger pains and therefore not being as successful in their cessation. And it might also just restrict their ability to visualize a realistic pathway for their happiest, healthiest self. And in this kind of a situation, food is central. It's not an option. Having access to healthy food for security purposes has to be part of that plan, that overall medical plan. No option there, right? And then as people's food and nutrition security stabilizes, available executive functioning, cognitive bandwidth can open, and we might actually see, opportunities for food as medicine to more radically, reduce or eliminate prescription drugs, reverse chronic disease, improve longevity, being more confident in perhaps undertaking some of these more extreme diets that we know are highly therapeutic, but that often are more challenging to implement. So it's a staged approach. And we need to think about what the expected outcomes are that are acceptable for both of these interventions, as well as the activities that we're baking in there to help make sure people are successful. And so hopefully these frameworks have provided you and your team with just a couple of starting points to print out, think about, talk through as you work through your different food as medicine program activities. But I thought it would be good just to kind of conclude with the AMA Code of Ethics. That's part of what we are all committed to in some degree of providing ethical, competent medical care, right? And thinking about who then should the priority population be for food as medicine. And I've highlighted a couple of key parts here, actually under the patient responsibilities in that code of ethics. And it says, successful medical care requires ongoing collaboration between patients and physicians. The partnership requires both individuals to take this active role in the healing process, which is what we expect in lifestyle medicine too, right? Autonomous, competent patients control the decisions that direct their health care. And with that exercise of self-governance and choice comes a number of responsibilities. And that patients should contribute to this collaborative effort when, dun, 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 They recognize that a healthy lifestyle can often prevent or mitigate illness, take responsibility to follow preventive measures, and adopt health-enhancing behaviors. So for me, food is medicine is actually working to achieve and support all of this. It's working to help people get to a point where not only is their nutrition security restored, but that they're more stabilized to fully engage as an active participant in their healthcare and their health. And so thinking about the cognitive burden of poverty, or alternatively, other health conditions or events, how might that impede patient capacity and autonomy to do these things? And what is our ethical obligation as providers to respond to the needs that our patients have so that they can fulfill their shared role in that medical, as part of the medical care team? So I'll be concluding with this kind of more tangible model that we've come to use in culinary medicine here at the university, thanks to one of my occupational therapy colleagues. And this is this introduction, this idea of this person, environment, occupation model as a tool of really thinking about how can we improve the fit of what we're trying to get people to do in these programs. And it begins in thinking about, individual assessment of the patient, of the person, really thinking about what behaviors are they most interested and ready and confident that they can initiate some change in, and having a program that's designed so that it can meet them where they are in those desires, and then having some strategies around those particular skills and abilities that they might need to actually be successful in performing that behavior. But then similarly, thinking about the occupation of eating, thinking about and looking at the actual foods that we're supplying in these interventions, and realizing, that there's a lot of either barriers or facilitators here that we can use in the modification of these foods, procuring, preparing, actually eating that. What can we do to help people be more successful in that occupation? And finally, thinking about the environment. Where is this person living? What does that home environment look like? Do they have the cooking appliances that they need? If not, do we have additional supports built into our budget and assessment protocols built into our budget to give them the additional things that they may need to be successful? And these don't have to be high dollar items. This could be a rice cooker for cooking intact whole grains. It could be providing people with a crock pot if you're giving dried beans. It can also be low-tech things like sending them a text message reminder, reminding them to eat the foods, recognizing that with the cognitive burden of poverty, there's a lot of day-to-day things that happen, and a gentle, supportive reminder of like, hey, we're working on this week can be very helpful and useful if they agree to that. This final slide here is just a still work in progress, but if only one message sticks out from today, it's that I've come to conclude that good food is medicine program design, it's got to be more than just about the food. My views on the strategies that we've talked about and that are listed here, kind of based on people's stages of change and readiness, are informed through my professional work as a dietitian, as a researcher, and could only have been possible through collaborations with Tulsa Cares, which is Oklahoma's largest HIV social service organization, our food bank of Eastern Oklahoma, and then more recently through my collaboration with the Kansas Food is Medicine Initiative, as well as Women in Recovery. There's still a lot to learn, and I'm sure you all might have some ideas about other strategies that you've found, and I would love for you to type those in the chat today as well about how to support people and meeting them where they are and moving through this progression. And to conclude, this is why process evaluation is so important. And this is why transparent reporting of program activities, beginning from screening to discharge, is so important so that we can understand how these programs are working or not working, their impacts, and then how to improve them as part of a commitment to continuous quality improvement for the people that we're trying to serve. So with that, just like to give a final acknowledgement to the people in the communities that have shaped my views and reaffirmed my commitment to food as medicine. The picture that's here was desperately needed at a time from a research participant who sent it to me when we were in the midst of a very difficult food as medicine research study. And I was wondering, is anybody looking at the content in their boxes? And he sent this to me from his kitchen. So it provided much comic relief time when I needed it. And then please also say hello, drop me a line. Happy to collaborate or share at no charge the resources that we've come up with.
Well, thank you, Dr. Wetherill. That was just a fantastic presentation, and that's very evident by the number of questions that have come into the chat box here or into our Q&A feature. And so I would love to go ahead and actually pose some of those questions to you here. And so you spoke about the cognitive burden of poverty as well as empowering patients, and not only the patients, but families. And so one of our questions here is specific to the unhoused population. Can you speak to any programs that you're aware of that focus specifically on unhoused persons and specifically their limited resources for preparing food?
Yeah, that's such a great question. And there's very limited data on the nutritional needs of people who are unsheltered, which I think is a huge equity issue. Like, we need more focus on that because I do think that that's contributing substantially to, the downstream effects of, mental health severity that we see and cardiovascular disparities that we see in this population. And from what we do know, oftentimes the foods that are available are very, very high sodium and really also contribute to physical discomfort, feelings of being bloated and just yuck all throughout the day. We initiated a project a couple of years ago with our largest soup kitchen in Tulsa to conduct a nutrition needs assessment. We found some very insightful things, and some of the high priorities that we found included really just documentation of the oral health chewing barriers that affect this population. 50% had problems chewing food. So if you think about many of these foods and recipes and things like that we use in lifestyle medicine, they truly just aren't accessible to them. And so we were able to work with the soup kitchen to design some tailored menus, tailored recipes that could be integrated into their menus. And so I think for many of these sectors, working with the charitable feeding operation, they want to be part of this solution. They just might not have been able to implement these changes due to lack of financial resources. And so with that, exciting investment opportunities with food as medicine, let them do the work that they want to do and provide them with the medical and nutritional expertise to implement those changes. So that would be my response there.
Yeah, that was great. Continuing along that same line, there's a question about implementation science in particular. It states here, as an implementation scientist and researcher, I would really like to use more implementation science and behavior change theory to build programs. What specific implementation strategies can you recommend to integrate into food as medicine programs?
I think kind of a regret that we've had in our data design, and I agree, implementation science is desperately needed in food as medicine research. Is we've focused a lot on the patient level, like are they eating the food? How are they using it? Why aren't they eating it? And like, yes, at a patient level, that's good, but how are the healthcare providers and healthcare systems engaging with the new intervention, this novel innovation that's in healthcare? And we've found anecdotally that there might only be one provider that's championing it, even though there might be 10 prescribers that could. Why is that? So I would definitely say embedding some of that, into the design, and then also looking at the food system. So whoever that food system collaborator is, what are the challenges in sourcing the food that you're needing? For example, is it actually being delivered in the way that you had intended it to be? And I think we can learn a lot from the tobacco cessation literature, looking at how those cessation interventions have played out and modifying it to include food as medicine instead.
It's an excellent point. I hadn't thought about considering sort of marrying that with the tobacco cessation
Yeah.
interventions. They've been very successful, to your point. So that's a great suggestion there. Another question here asks, can you get the medically tailored groceries with SNAP? If so, where are they available? Fresh produce products, specifically produce prescriptions, are not available everywhere, especially in many rural areas where there are food deserts and the elderly cannot or will not be able to prepare food.
Yeah. This is a big scientific gap of knowledge of just how do you implement food as medicine in rural areas in particular. And so I think there is a pretty strong need for a collective of particularly rural food as medicine practitioners to come together and exchange these best practices. What we know keeps a community viable is the local grocery store. And we have been, trying to reflect with the Kansas Food as Medicine initiative. How do we make sure that these food as medicine interventions and investments can keep the grocery store open? Because without that, then the health of that whole rural community crumbles. We do see some innovative, interests, like, for example, with Instacart and other mobile, disordering and distribution platforms. But again, those may not be available in the rural areas. And then finally, there may not be federal produce prescriptions, but sometimes the very local philanthropic organizations can see the value. And so reaching out to them and seeing if they might be willing to support some investment in that area.
Great response there as well. And as you responded, I'm hearing this theme of collaboration and partnership, especially with food as medicine, is needed, right? We have to partner because there's not an end or a surplus of funding available. So one other question here as we start to round out the webinar is, how can we better connect lifestyle medicine practitioners to food as medicine providers, such as Meals on Wheels or other programs that can help them serve individuals who need MTM and other food as medicine programs?
Yeah. I think lifestyle medicine has a lot of expertise to offer some of those nonprofit food providers that haven't yet amped up their game to make the food fully therapeutic. And so I would encourage lifestyle medicine practitioners to have a small convening of people in your community, including Meals on Wheels. Ask, like, what therapeutic diets do you offer? You may be surprised that it's not really all that you had thought. How could we advise and help support you in making some modifications that they're more therapeutic and taste good and all of that? But really, I think for food as medicine to honor the model, and we know that it works when it's community based and local. So how can we come together and form solutions collectively that meet that address the needs of the people that live in our community?
Wonderful. Well, we are out of time today. We thank you so very much, Dr. Wetherill, for taking time to share your knowledge of the Food is Medicine movement and nutrition equity. And to our attendees, we also thank you for taking time to be with us this afternoon and for your engagement. This webinar was recorded and will be available on our Connect platform. And we hope that you will join us on February 18th for our next webinar, where we will be focusing on the 2026 physician fee schedule updates. Thank you so much and have a great day, everyone.